having both an effective and usable intervention, as well as having effective implementation methods and enabling context, which gives the social significant outcomes. So we are not that much concerned with the examining of effect of an intervention, as most research often are. We are more interested in the uptake of the intervention and practicality of it. So my PhD project has two main purposes. First of all, it is to explore factors that are involved, including the characteristics of the students, the organization at these schools, and the intervention of a Gatekeeper teaching program that is aimed at teaching staff that work at schools with high-risk youth. And the second purpose is to develop, plan, and perform a feasibility study of a Gatekeeper training program where the implementation has been guided by a thorough exploration and of contextual factors and the investigation of the suitability of the intervention as well. So it's a big one. So just to tell you a bit about the context, it's a specific school type we have in Denmark that are called preparatory basic education and training. They are for youth aged 15 to 25 years old. The reason they go to these schools is that they have academic, social, or personal problems. And we know that about 1/3 of them have a psychiatric diagnosis. The students have many risk factors and a few protective factors for suicide behavior. And we also know that more than half of the teaching staff have experienced students with suicidal behavior, and 1/3 of teaching staff have found a student who had attempted suicide. So it is really a high-risk environment we're working in. Just to explain the intervention, a Gatekeeper is a training model where you train people to identify individuals at risk of suicidal behavior and then assist them to get help. There exist different kinds of training programs. The most known ones are ASSIST and QPR, and then there are theory-based and people who just self-develop them as well. So to frame my PhD, I'm using the implementation stages framework, which is a framework developed for school implementation of interventions. And it also shows how implementation isn't just a linear process, but as well as going back and forwards, and that the stages overlap each other. So to put the so in this framework, I put a scoping review on school-based suicide interventions. And then I did a qualitative study of organizational and leadership level at the SHW schools with single and group interviews. I was meant to do an observational cross-sectional study on the students' suicidal behavior, but due to practicality and schools' anxiety of addressing suicidal behavior among students, I was not able to do that. So this is going to be a register study instead on the education attendancy trajectories related to suicide attempt, repeated suicide attempt, and suicide and self-harm. And finally, I'm doing a feasibility study with a hybrid design. And a hybrid design means that I'm both looking at the effective of the intervention as well of the implementation strategies outcomes. So I'm looking at several outcomes at once. So as the first part of the exploration stages is doing, or the implementation stages framework is the exploration stage where we assess needs. And that was done by this qualitative study among the organization and leadership. And then we are going to do a register study. I previously did an observational cross-sectional study that has been published about the capacity to implement a Gatekeeper intervention in these FGU schools in Denmark. And we did a scoping review. So the aim was to systematically map and synthesize the existing literature on suicide prevention Gatekeeper interventions for teaching staff implemented in schools. And we included 43 studies, and the aim was to identify or we found that the training often aims at identifying individuals at risk of suicidal behavior, being able to intervene on them and refer them to help. And the most effective components were group lectures conducted by external, or not effective, but often external personnel were used, and the Gatekeeper training should consist of an in-person training with role plays or discussion, as that led to people having more behavior change compared to just theoretical knowledge. And the only Gatekeeper program that actually was studied in our CT study was QPR, the rest weren't in schools. So level of evidence is not that high. Then we established barriers. So we did a needs assessment for the implementation, not a needs assessment if it is needed, but rather what is needed to implement this. So we established barriers and facilitators. We explored, as I previously told, in this nationwide observational survey study, do they have the readiness to implement this intervention? And then we did a qualitative study of the organizational level to find barriers and facilitators for this intervention overall. So we established 12 facilitators and barriers for the implementation of a Gatekeeper intervention, mainly barriers, which often is the case. But one of the facilitators we found was actually that they, in these schools, have something called student coaches. They have a function of being guides for the students, and as well as having a much more integrated correlation with and work with the teaching staff as well. So they are working in collaboration with quite more. And they had a much more knowledge about suicide behavior among students compared to the overall teaching staff. So that was a great barrier to use. Then to find out what implementation strategies we needed, we used the COM-B model, which is a model of how behavior is affected. And the COM-B model says that capacity, motivation, and opportunity affects behavior. Right now it's in Danish. I just saw that. Whoops. Didn't notice that before. And then we use these strategies or these behaviors and put them into the red round circle of the behavior change wheel to find the strategies we needed to apply to change the behavior or to use the behavior that already existed. This led us to different, again, I can't remember if it's 13 different strategies we implemented, but for one of them was environmental restructuring we could do that by physical capability, for instance. And we also had something like automatic motivation, which was a behavior which can be changed by enablement. So our strategy was actually ending up being that we would train the student coaches, not only as QPR gatekeepers, which was the one we ended up using, but also being instructors for the rest of the teaching staff, because they could model behavior. They can also become a point of referral for the teachers and increase collaboration as well. Then we found that it was a barrier for them, that they were worried about the youth and didn't about the students, there was a discrepancy between when they thought a student should be in a psychiatric ward and when they should be home, and they were taught about that as well and trained to do safety plans and things like that. So a huge intervention with an implementation intervention as well. So we are going to do this hybrid feasibility study where we are doing a pre-post design with 6-month follow-up, looking at both all participants, the student coaches that are trained instructors and safeholding, and the teaching staff that are trained gatekeepers. And we're doing that with surveys at 2 levels, at 3 time points, as well as field observations, which I have done already. And then we use the measurements of the revised facts of risk of suicide and willingness to intervene, and also function and use of implementation strategies assessed. Finally, we are going to do this register study. Luckily in Denmark, we have this personal identification number, which means that we can correlate different registers across different fields. And this means that we can use somatic ICD codes, psychiatric ICD codes, death registers, education attendance, and social registers such as being in foster care, and even exposure to sibling and parental suicide attempt or death or self-harm. So we're going to look into how these exposures affect the outcome of suicide attempt or repeated suicide or suicide attempt or suicide or even self-harm. Yeah, so that's my little thing.
Very much. Questions?
Any questions?
Fascinating work. Can I just ask in terms of your barriers? So you found that teachers, you had quite a few barriers. So how did you then decide to pick them as a group? Why not some other professional group embedded within schools, considering that there were so many barriers? So in Finland, for example, the suicide rates have dropped because they embedded psychologists within schools.
Yeah. It was, first of all, it was a way to try to use the things that already was in place, because it was meant to be a sustainable intervention. So the point of using the student coaches as instructors was as well that we would be able to leave afterwards. So if it's no longer funded, it's not a problem, because they can keep on being instructors, keep on training gatekeepers, but as well as they have a more daily meeting with the students. They are daily in the schools, and the schools aren't big enough to having each school having a psychologist hired for the students. It's not feasible. And overall, the youth education in Denmark already have psychologists, but the students didn't go to these psychologists because they didn't know how to get referred there. So the problem was actually getting them referred. And this was a way to getting them referred and get them help. It could be a school psychologist, but it could also, because we have these councils or municipalities that offer a wide range of health interventions and social interventions, but the youth do not get there. The students do not get into these interventions, so we wanted them to go there. So we also, one of the things, couldn't explain that, but we made a long 18-page list of interventions and places where the students could be referred to depending on age and needs. So we used different points, but it was to help the students get the help, get there. That was the point of it, main point. Yeah.
Question online? Okay. Thank you very much. Hold that for you. Thank you. And next we have
Ramesh, I cannot hear you.
Panic not. Can you hear me
Yes,
now?
now. Yes, now, yeah.
Okay. Are you okay to share your presentation with us
Yes,
now? Great.
yes, I do that.
I'll just turn the volume down a wee bit because at the moment you're quite loud. Would you like me to let you know when there's 2 minutes to go?
Yeah, that would be helpful. Yeah, you can do that. I just share my screen now. Yeah. Can you see my screen?
Yes, we can.
Yes, you can, yeah. And it's the presentation mode, right?
Yes, we can see it
Yes.
in presentation mode. That's great.
Okay. So yeah, hi everyone. I cannot see my audience. I couldn't be there unfortunately, but I'm still happy to present online. Yeah, so my name is Auriba Raza and I work at Stockholm University. The title of the presentation is Warmer and Darker Climate, Impacts on Mental Health. This is the title of my ongoing project, and I will present one of the studies from this project. But before I do that, I want to introduce myself. Yes. No? The slide did not change. Yeah, now it did. Yes. Yeah. So the reason here to present is not only to share my work, but also find people, like if you see common interest, I would like to collaborate. And if you see anything that you're interested in my work or find it interesting, so we can I can find like opportunities to collaborate, write project grants or something, yeah, or a paper, maybe work on a manuscript together. I will be really happy to collaborate if you see any interest in my work. Yeah. So to begin with, I have a PhD in environmental medicine, and my PhD work was more on short-term effects of air pollution on total and cardiorespiratory mortality, out-of-hospital cardiac arrest, and cause-specific morbidity. Then I have a postdoc from Stockholm University, where we looked at home and workplace, the location of home and workplace matter for different health-related behaviors. And here we more looked at the proximity of alcohol outlets or proximity of different sports facilities to home and workplace, and see how they affect behavior-related health. And then for a short period of time, I worked at Karolinska Institutet, where I gained some experience in occupational epidemiology, and we looked at regional differences, trajectories, and predictors of a sustainable working life. And currently in my work at Stockholm University, I'm working on 2 projects. In one project, I'm looking at how the remote work, or the pre-pandemic and pandemic time affect the behavior-related health of remote workers. And we are also looking at the change in the commuting behavior and more and time or distance in commuting, how this affects healthy behaviors of remote workers versus passive workers and active commuters. And in the current project that I'm going to present now, we are looking at the mental health impacts of climate change. And the study here in this project, we are focusing actually on meteorological parameters, weather parameters, which are related to light, say like global radiation, precipitation, and snow cover, and how these impact the mental health of Swedish and Finnish population during winter months. And this, in this study, we have looked at daylight during winters and symptoms, self-reported symptoms of depression and sleep problems in Sweden. And here I used fixed effect methods. And this project is a collaboration between Finnish Institute of Health and Welfare and a Swedish Meteorological and Hydrological Institute. Yeah. So just brief about what is there in the literature. There are not many studies, at least when I started working on the grant application, on the associations between global radiation or sunlight or sun duration and depression. And the findings were a bit inconsistent, even for the studies which came from the same setting. A Korean nested case control study, they made their exposure as a duration of sunshine and observed that the long-term shortened duration of sunshine was associated with the increased risk of depression. Another Korean study, which used time series data, they observed that a 1 month cumulative exposure to low amount of sunlight had significant effect in reducing hospital visits due to depression, specifically in the months of January, March, and May. Then we have a Finnish study that used 1 year global average radiation. It was a long-term exposure. And they did not observe associations between global radiation and total depressive symptoms. But in symptom-specific analysis, they observed that participants who were exposed to higher levels of solar radiation were less likely to report suicidal thoughts. And then there's a study from Netherlands that included participants with seasonal affective disorder, and they were the only ones who collected data in winter season. And they observed protective effect of 1 week lagged exposure to global radiation on depressive symptoms. But they observed opposite effect for the sunlight duration. And then there is a British study, and I think they used UK Biobank, data from UK Biobank, and they looked at self-reported time spent in daylight. And they observed both cross-sectional and longitudinal associations between time spent in daylight and lower odds of depressive disorders, antidepressant usage, and greater happiness. So that was a bit about what is in the literature. So now I move to why this is important to study in Scandinavian region. In Sweden or in northern latitudes, winter depression is common. In winter, it's very common, people talk about winter depression. And they complain about it's very dark outside, and you see in everyday conversation that people bring up how sad or depressive the winter in Sweden is. However, though when I was working on the project grant application, I found many blogs written by natives or foreign students to guide foreigners on how can they survive dark Swedish winters. But I did not, to my surprise, we did not find a strong scientific evidence or strong scientific studies where they have looked at the associations between sunlight or actually the ambient exposure and how they impact the mental health of the people living in these areas. And the climate change, if we talk about from the perspective, climate change for Scandinavian countries, it means that winters are going to be warmer, but more likely to be darker as well. Climate projections, which are performed by Swedish Meteorological and Hydrological Institute, they indicate that an increase in winter temperature by 5.8 degrees in northern Sweden and 4.5 degrees in southern Sweden by the end of this century. And rainfall is also expected to increase significantly, and consequently, the number of snow days are expected to reduce by 40 to 80 days. And see, this is a whole season. If you look at, for example, in Stockholm, it's the whole season, which is going to be like snow season, going to disappear. So while the changes in climate and winter patterns have been observed and predicted for this region, the effects of reduced daylight during winter months on mental health has not been studied. Therefore, in our project or in our study, we proposed to look at or to investigate the associations of objectively measured wintertime global radiation and of self-reported exposure to daylight in winter months with self-reported symptoms of depression and sleep problems. And to study this, we used a data from our database, which is called SLOSH. SLOSH is an abbreviation for Swedish Longitudinal Survey of Health. And I would like to take the opportunity to briefly introduce this dataset. If you might be interested in using in your studies, it's a nationally representative sample of working population. It was established in 2006 as a biennial survey with an aim to study work-life participation, work environment, and well-being. But since 2023, we are sending questionnaires annually. And this is, in total, there we have about 55,000 participants, and all the participants are linked to national registers. And for this study, I use 3 waves from SLOSH from 2012, 14, and 16. And our analytical sample is of around 15,000 individuals. As said before, our outcome is self-reported symptoms of depression and sleep problems. And these were assessed using well-developed scales. For exposure, we used 2 measures. The first one is subjective exposure. And it was self-reported time spent in daylight from November to January during business days and days off. These are November, December, January. These are the darkest months in the year.
That's
And
2 minutes.
already, okay. Sorry. So okay, I'll go quick. Yeah, we categorized the time into 1 hour, less than 1 hour, and more than or equal to 1 hour per day. And my second exposure is objective, that is global radiation. And just a quick review, it is actually the global radiation is sum of the scattered, direct, and the diffused sunlight. And we used 3 windows, 3-month average and 4-month average. Yeah, so I'm almost there. And we see that in our findings, we observed a protective association between exposure to global radiation and symptoms of depression. And our self-reported exposure complemented this finding. However, with the results of sleep were inconsistent. And if I go to, so based on the results, we concluded that the brighter winter conditions may contribute to a decrease in self-reported symptoms of depression. Well, I will skip some slides and directly go to where we communicate our results. So just ending on a lighter note, we maybe make an effort in communicating our results into a broader audience. And we think that it's very important, and we put extra effort on this. So in Sweden, we have a day which is in Swedish called Forskarfredag, which is in English is Research Friday. And where students come to Stockholm University, and 3 main universities from Sweden, from Stockholm, they present, researchers from these universities present their work to students, high school students, and 9th and 10th grade students. And you present them your work in the form of informal presentations, or a visit to labs, or your workstations. So there I presented the same study, but in a very informal way. And it was really good experience, and I could see that the students were really interested in knowing more about our research and work, and they could really associate that, okay, when we presented my work, they really could feel that, okay, yes, this is how we feel during the winters, and they were really interested in knowing why this happens. So yeah, that's all from me, and I welcome, if you have any questions, I'm happy to answer. And sorry, I'm a bit behind my given time, but if
That's
you
great.
haven't couldn't manage to ask, you can also contact me on these email addresses.
Thank you very much. That was really interesting. Any questions from anyone here in the room regarding daylight exposure and mental health? Anyone online? No. I had a question for you, Auriba. I was really surprised about the lack of evidence that you mentioned at the beginning of your presentation. I mean, seasonal affective disorder is something that I thought that there would be more evidence around. Maybe that's a specific element of what you're talking about. But can you say anything about that? Were you surprised about the level of evidence when you started looking into this?
There were studies on artificial light, and when you people are also often recommended that they were given light treatments, artificial light treatments. People who have seasonal affective disorder, it's kind of a known thing. But when it comes to ambient exposures, there were not many. Many studies, and the studies that we found were coming from tropical and subtropical regions. And but when you talk about light means it's different when you talk. People take, if you see study from Spain, and they look at light, they might find negative associations, like people feel more depressed when it's more light. But when you move to Scandinavia or to more north side, it means different. It's a different meaning, especially during winter months.
Okay.
And yeah, there are studies on artificial lights, indoor lights, but on ambient exposures there were not many.
We have another question in the room. I'll just bring the microphone over. Alistair, right at the back of the room.
Thanks very much for your talk, Auriba. I really enjoyed it. I just wonder what you thought about the policy implications, or in terms of interventions based on establishing these associations. Like, how do you think it will affect populations or patients?
Yeah, we recommend that maybe people can spend more time outdoors, and promote more winter sports, and participate in winter sports and be physically active. During this time, when you're physically active, you go outdoors, you spend more time in daylight. Yeah, and for clinicians, I think it's there is a good kind of good knowledge, or good the evidence in the literature that exposed to light people are more. It helps to. It helps their condition with seasonal affective disorders and stuff, but it's good to spend more time outdoors, daylight. Maybe the spectrum is different or whatever, I don't know, but it's more beneficial when you spend more time outdoors during the winter time.
Great, thank you very much. Okay, thank you very much, Auriba.
Thank you.
You don't mind stopping to share your screen?
Yeah, I do that.
You can
Stop share. Yes.
please current share. then put that on in the old way. Okay.
Thank you very much.
So, okay. Thank you.
Okay. Hello.
Introducing yourself.
What?
People here online.
Hello. Okay. Thank you, Hamish. My name is Ruchika Gajwani. I am a researcher and a clinical psychologist in mental health and well-being. And I'm talking about work leading up to our clinical trial called the Bridge Study. It was a feasibility randomized control trial with young people between the age groups of 14 and 25 that met criteria for borderline personality disorder features. It was the first community-based trial for young people with BPD. I want to acknowledge right at the outset that the language and attitudes around BPD continue to be, that's okay. The language around BPD continues to be very challenging, and there are negative attitudes that make it really hard for young people who are in great need of accessing care. So this is a young person who says, I have to keep a secret. Because people say, don't be friends with someone with BPD because they're manipulative attention seekers. They might not want to be my friend or date me, which hurts because I'm trying to get better. It's not my fault. BPD is associated with stigma, not just within the self, but structurally, publicly, systemically, and that really affects people receiving care and an appropriate diagnosis. So there's a delay in diagnosis, and often actually a misdiagnosis or labeling with other conditions. And what that does sometimes is not providing appropriate care at the right time. It's created a clinical culture that we avoid any discussions around personality disorder. So there are young people that then often go into crisis to try and get the right support. And that's really, really problematic. And what it does is it further stigmatizes young people and families in accessing care. We did a systematic review and found actually clinicians dating right back to the 70s to now talk about how BPD is problematic, and it's a construct that they don't want to engage with. What that does, it really perpetuates actually poor access, both from service providers seeking care, but also service providers trying to provide care, and it creates iatrogenic harm. So people then end up in really problematic engagement with services. To get a diagnosis of BPD, the DSM proposes that the person, not just young persons, the person meets 5 of the 9 domains. There have to be persistent patterns of difficulty in these areas. What that actually creates is a real heterogeneous. So you can have 256 different combinations in BPD. And this is really quite relevant. I'll come back to this because we went for a sub-threshold criteria for our clinical trial. But currently, to receive a diagnosis of BPD, you have to meet 5 out of 9 criteria. Persistent patterns means at least for a year. So long-standing difficulties in these different domains. What really it is difficulties in functioning within the self and others. But what we end up focusing often is on self-harm and suicidal behavior. We actually don't have a very good understanding, at least clinically, in terms of how these other difficulties present. So where are the gaps? We know BPD presents in 40% of psychiatric inpatients and 20% of outpatients, but people are generally seen for other conditions such as eating disorders, psychosis, major depression. And if left untreated, it impacts long-term functional outcomes in the form of unemployment, homelessness, seeking disability benefits, multiple contacts with the youth justice system, and sadly is associated with very high levels of premature mortality. But again, clinically, I think the focus tends to be late, and it tends to focus on crisis and self-harm, and that then perpetuates the cycle of negative health seeking and iatrogenic harm. What we also know is that children who meet, young people who meet criteria for personality disorders have very poor transition from CAMHS to adult services. And we also know that CAMHS are overstretched. And yet there is evidence that BPD is treatable. So we had a study funded between 2016 and 2018 by NHS GTC, and they were looking at improving pathways for young people with personality disorders. And within our study, we wanted to look at developmental features. What is it that contributes to these features? And what was really interesting is that neurodevelopmental conditions were really poorly missed in this group. And this will come as no surprise. So only 13%, 1-3, were diagnosed with either ASD or ADHD, but actually 78% met criteria. And this was really, really relevant. And what's stark is that neurodevelopmental conditions are particularly missed if there's any indication of trauma. And so just something for us to keep considering. So I just want to share a video that we set up in preparation for our bridge trial. I hope that.
48 young people who are attending different classes. These young people that had problems that had been going services were struggling to find solutions for. Despite the complex nature of their problems,
So the feasibility study ran from 2021, and we've just finished data collection in 2024 December, and we're just in the process of analyzing our study. The main thing that we were looking at in feasibility studies: can we recruit young people from the community, and can we retain them? So these are young people that are often seen as hard to engage and are excluded from several services. So we want to see within the community-based trial, can we engage them and can we retain them? And then we followed them up at 2 time points. So going back to the criteria, using the model of early intervention and prevention, we use sub-threshold criteria. So 3 upwards, anybody who met criteria, so that's persistent patterns of difficulty in 3 or more of these difficulties, and not all of them actually at the time had suicidal attempts. So our focus really was around prevention and early intervention, and 3 upwards. And I guess you could argue, why not 1 upwards? Because actually what the literature shows, if you meet one of these threshold criteria, and if it's left untreated, it impacts long-term functioning. So just in terms of clinical caseness, we had to draw a line, but I'll come back to it because our findings have been really interesting in terms of functioning. In terms of recruitment, it was almost like a public health community approach. We spoke to not just people in the NHS, the third sector, GPs, violence reduction units, social services, youth justice, because really the idea was, how can we engage people who are working with young people? We also advertised on the subway, so we had grandparents, parents referring to us. I've not put in a picture of our website, so we had all of our recruitment through our website. Happy to say more about it. So 50% of our young people were randomized to the bridge intervention. And to tell you very, very quickly, we did comprehensive assessment of needs. So if you go back to thinking about James, we know that actually his quality of life, functioning, ADHD were missed. So it was really important for us to capture and do a comprehensive assessment for our young people. Up to 16 sessions of cognitive analytic therapy, and I say this every time, actually, it's not just cognitive analytic therapy. There's really good evidence for good clinical care, which is currently missing for people who meet criteria. And using principles of a relational psychotherapeutic model, we did a lot of contextual work. So for a young person, it might be that we just work with them. For a second, we had to engage with CAMS, their college counselor, their social worker. For a third, it might be their foster carer. So it was really about contextually engaging with the person's milieu. In terms of our recruitment, so 84 young people consented to the study through the website. Of those, only 7 didn't meet the initial criteria. Some of the people were excluded because they were out of area or had received previous treatment of BPD. But what the 84 in itself is telling is the high level of unmet need within the community. We did 52 diagnostic assessments. So we saw 52 people to see if that they met 3 or more of the criteria on BPD. And out of 152, only 1 person didn't meet 1 threshold criteria. So almost everybody had at least 1 or more of threshold criteria. And because our cutoff was slightly higher of 3 or more, we were able to randomize 25 young people. And our retention rate at 6 months was 92%. In terms of the statistics, what's not, I mean, this is there in epidemiological studies, but there was high level of suicidal behavior in the last 2 weeks and a lot of comorbidity. I'm just going to move forward. There was really poor functioning across the board, whether it was 1, 2, or 5 threshold criteria. So it doesn't matter if you're sub-threshold or full threshold, functioning in terms of health, quality of life, educational attainment was poor across the board. So you could argue, actually, should we really be focusing on functioning, really supporting young people where there is marked functioning impairment? In terms of a qualitative study, so Kirsty is doing her PhD, and she interviewed our young people. And this is a quotation where one of the young persons said, the doctor wasn't keen on it, because I was 17. They mentioned the Bridge Project and they said that there's not a whole lot that we can do for you. We can give you the medication and help manage your symptoms and sleeping problems, you know, trying to keep the mood swings kind of as small as we could get them with the medication, but there wasn't any other options available. And so they mentioned the Bridge Project and were like, here's something, it's experimental, it might work for you, but we'll send you on your way. Another young person said, you fell through the cracks quite a lot at the time. And the guy, he was lovely, but it was just very much tick box exercise. I don't feel like there was much, even the substance in any conversations we had. There was only ever crisis support, never like any therapeutic work. We also spoke, so a trainee psychologist has just recently finished the project on speaking to parents. And what the parents have said to us with amount of missed opportunities. These are young people who are known to various services, but they were never asked the right questions and not given the support. So it's quite difficult to access services unless you're quite high risk. You know, I think there was a role for the community mental health team at one point, but it didn't really come to anything because she wasn't high risk enough. We didn't meet the bar or the criteria. So parents have told us that they've had to go to their MSP to try and get services because they're unable to get in. That's just another quote from a parent who said, I was told you have to get the police involved. That's the quickest route to getting services. And sadly, that was the quickest route. And the young person, of course, in despair saying, you don't understand how terrified I was then. And the parent says, I explained to you, you keep this up, I have to phone the police. You're sitting on a window ledge, about to throw yourself off. I don't have any other options. You know, I have to phone the police. So in terms of the evidence, where are the gaps? Currently, the effects of the psychotherapeutic treatments are small. They don't quite meet the scale of the difficulty. So what we're really proposing for our definitive trial is a realist evaluation of scaling interventions. We recently got funding to look at digital optimization. What we're told by clinicians, there's a huge gap. They want training, they want support and supervision. And so we're really looking at how can we bridge the gap between primary care and secondary care and do some cross-professional training. And, you know, we have the support of Scottish Government Personality Disorder Improvement Programme. So keeping fingers crossed, we get the funding. Thank you for your time.
Very much.
That's all right.
Anyone, any questions here for Ruchika?
Oh.
I think that's really interesting. So I'm just wondering, why is it that clinicians are resistant to diagnosing appointments? And what was done to that?
Did people online hear that? Maybe
Oh,
repeat that
sorry.
question.
Did the people online hear that?
We
Joe,
can't
just
hear that. Sorry, we couldn't hear the question online. If you
Okay, I'll try and repeat it. So Joe was just asking why there's a lot of reluctance amongst clinicians and what we can do to improve it. Oh, the brain's just gone. Is that okay, Summer? I think there's a lot of misinformation and myths around what BPD is. So for example, the name doesn't do itself a favor. And so people assume that it's to do with personality being disordered, and it's not. It's that's why those domains are really important. It's difficulties in functioning within the self and the other. Done so many presentations where I actually have to really challenge the assumption, because the assumption tends to be quite pejorative. It's around people being in crisis, which is only one of the domains. And it's actually not even crisis, it's suicidal behavior. And people tend to see manipulative behavior, which is really troubling, because these are people who are suffering and really want to get help. So there's a lot of myths around the concept of BPD. And that has been going on for generations. So we really have to try and challenge. If you look at actually the prevention model and the earlier, our young people go right back and they'll tell you where it started, their difficulties, but actually around the age of 11, 12, 13, it's difficulties in self-identity, but not self-identity as I'm not quite sure what I want to do. It's to do with really feeling challenged within themselves, and it's long patterns of difficulty. There's a lot of distress. So I guess what a short answer is, there's a lot of work that needs a public health approach in terms of having a conversation around BPD. And I can only draw an analogy to, I think, psychosis work, where there was a lot of work within the public health with GPs, social workers. What were the early signs of psychosis? So we need something similar. The funding in terms of BPD is very, very poor. Even within mental health funding, research funding, BPD gets 1%. So these are the most excluded people who we then continue to exclude because it's difficult.
Question online.
There's evidence that people with PMDD can be misdiagnosed as bipolar. Hormones can exacerbate existing conditions. Did you explore the impact of hormones within your study? Yeah, I think that's very true. So there's both misdiagnosis. Julie, thank you for your question. And we've had young people anecdotally tell us, in fact, we've got a lived experience expert researcher who talks of her own experience of misdiagnosis, and BPD is almost like the last resort. So, but we didn't look at the impact of hormones, although I think that would be really interesting to consider, the mechanistic side of, what else is going on in our population. Yeah. Thank you.
Thank you very much to all our speakers. If anyone would like to know work, please get.
Oh, how much we can't hear you again, your sound. We still can't hear you, actually. I don't know. No.
Hello?
Oh, yeah.
Sorry, a pitch to say, please get in touch if you'd like to help organize these sessions and be much better at controlling audio-visual controls than me. No, that's fine. So yeah, please get in touch. We need people to help organize these sessions, and they're very good, I would suggest, both for your CV and also for meeting people and collaborating with people across the university. It helps you get a better sense of what people are doing and why. So thank you very much, everyone.